if the audience can zoom this. Thanks, Matt.
Okay, take two. Now I've thought about it in my head. Now it's either shorter or longer. Good morning. So thank you guys for bearing with us as we get this, the technical difficulties handled. Hopefully everybody can hear us online. Welcome this morning to our Phoenix Children's Grand Rounds. It's my pleasure today, this morning, to introduce two of our faculty members who were part of our inaugural research mentor-mentee program. It's a program that Dr. Teresa Thomas and I started brainstorming about a year and a half ago, and then worked with our research and education committee and put together an idea where we wanted to really help some of our junior faculty, try to help our junior faculty continue meaningful research as they transition here, especially as early faculty. We know our faculty come from rich research and academic fellowships from around the country, our own fellowship programs, and how do we help them continue to do some of that work that they had already laid a foundation for. So I have two people to introduce, and they're kind of sharing the time today. So please first help me welcome Dr. Melissa Parks. Dr. Parks is a board-certified OB-GYN who specializes in pediatric and adolescent gynecology. She received her medical degree from Ohio University and a master's of public health from the University of Arizona. She completed her OB-GYN residency at the Eastern Virginia Medical School, and then went on to complete her fellowship in pediatric and adolescent gynecology here at Phoenix Children's. She's now practicing full-time as a gynecologist here at Phoenix Children's. Education and research have always been a central part of her practice, as well as mentoring future physicians as the assistant program director, as well as the research chair for the pediatric and adolescent gynecology department. She participates in various committees with the North American Society of Pediatric and Adolescent Gynecology and serves as a consultant for the Special Olympics here in Arizona. She is going to first share her experience and reflections on the successes of engaging in a research mentorship program. Our second speaker, I'll just introduce her back to back so that way they can go seamlessly between their presentations. But our second presenter is Dr. Erin Thornley. She is a pediatric intensivist and early career physician scientist. Dr. Thornley earned her medical degree from Nova Southeastern College, and she completed her residency training here in pediatrics at Phoenix Children's, and then a fellowship in pediatric critical care at Nationwide Children's Hospital. Dr. Thornley has an interest in basic and translational research with a focus on Staph aureus infection in children and an emphasis on how the bacteria alters the host immune response in acute infection, wound healing, and the development of skin cancer. We'll get a glimpse into this work today. So I'd like to first introduce Dr. Parks. Thanks.
Good morning. All right. So I've been with Phoenix Children's for since 2018. So as you heard, I did my fellowship here. I've really loved being a part of this institution. Transitioning from fellowship as faculty, I've had a lot of resources and mentorship. And when this research mentorship program was presented to me by my division chief, I was really excited about it. I've always had an interest in research. They've been a lot more smaller scale project, retrospective chart reviews, small prospective cohorts. And I'd always kind of dreamed of doing something a little bit more. And that's what my goal was in participating in this mentorship program, is like, how do I take my research to the next level? And so I'm going to start off today by just kind of going over what the mentorship program is, and then how I was able to take that into successfully establishing a phase 4 clinical trial here in our department. So first, we're going to go over the mission and goals of the research mentorship program. We're going to discuss how the mentorship program can help to develop and achieve your academic goals. And then I'm going to go over the clinical trial that I'm participating in. And so who are our leaders? So we all know Dr. Patel. and Dr. Thomas as well. So Dr. Patel is here at Phoenix Children's in our GI department. He's the division chief and also professor at the University of Arizona College of Medicine in Phoenix. And then for Dr. Thomas, she's the director of the Translational Neurotrauma and Neurochemistry Lab over at Barrow, and then also an associate professor at the University of Arizona College of Medicine, Phoenix. So the program was really designed to be an ongoing collaborative effort with an interactive kind of evolving process to it. So I think we can all agree from participants and from our mentorship leaders that what it kind of started out as and what it's evolved to has, changed as we provided feedback and as we kind of got into the nitty-gritty of the program. Overall, this program was aimed to assist mentees in identifying long-term goals and opportunities, and then the steps that are necessary immediately to help to achieve those academic goals. And then it just, really recognized the pivotal role that mentors play in shaping successful careers and attaining your goals. So we had 3 missions that were established. One was to facilitate new faculty productivity and engagement around research by improving networking, understanding institutional resources, and promoting collaborative environment. Also to increase national reputation through meeting participation, understanding research impact, and producing publications and getting our names out there. And then also to increase and promote work satisfaction by fostering community. So simply put, the mission is to support junior faculty in a variety of ways. So we started off, once we kind of put in applications of interest, and then we had a group of us that were selected. And once we were enrolled into this mentorship program, we completed a research skills assessment. So this is kind of like a nice introspective look into what have we done? What do we think are our identified risks, or strengths and our weaknesses? And then this was supposed to help for us to kind of determine what are our goals that we want to get out of this mentorship program. And then on top of that, we kind of extrapolated upon previous research positions, previous leadership positions. What is it that we feel makes a good mentor? And so Dr. Patel and Dr. Thomas kind of took all of that information. We also had nice meetings with them, and they tried to match a mentor based off of our interests and what our overall goals were. So the structure of the program was pretty variable. So we started off with sort of, introduction with the mentorship leaders, and then kind of that discussion to identify our assigned mentors. And then they helped to facilitate introductions between the mentees and the mentors. And then it was kind of on us to, have those meetings and decide, what do we want this mentorship program to look like? So I'll talk a little bit about my mentors, but initially we started to meet kind of like once a month. And then eventually, as we sort of made some progress, we started to space those out because it didn't necessarily need to meet on such a frequent manner. And, we do little check-ins through email and so forth. So, that was really tailored to the mentor-mentee kind of relationship. But in addition, the mentorship program we had various workshops. So we had the biostatisticians come and talk about how they could support us. The scientific core writers came, which for me personally, I found extremely beneficial. I had a project that I had written a manuscript for that honestly I thought was kind of dead in the water. I didn't think it really was going to be something that was turning into a publication. After that workshop, I reached out to the core writers, and they helped me to revive this manuscript. It's, submitted for publication right now. So far, I've gotten some good feedback. So I think, just on a little side note, this mentorship program helped me to identify the resources that I actually used and turned into something, into fruition. I really enjoyed when we would meet together and we'd kind of have almost like a little round table where we talk about what our current projects were, some of the successes, maybe some of the pitfalls or challenges we were facing. And then we would just kind of bounce ideas off of each other based off of other, maybe previous experiences. We'd get guidance from our mentorship leaders. So that was a really nice component of this program as well. We talked about grant opportunities. We were put into contact with individuals that could help us seek funding. I know that's a big barrier in research, and sometimes it's a little overwhelming of where do I go to look for these grant opportunities? So that was also another great component of the mentorship program. And then constant feedback. We were, giving feedback, quarterly, annual kind of check-ins and discussing like what we liked, what we didn't like. And that's kind of how I talked about this program sort of evolved from what it was it 2 years ago now? Yeah, to now. So who are my mentors? So Dr. Ko, she is the chair of the Department of OBGYN at Banner University Medical Center. And then Dr. Herbs Kralovitz. So she's the director of Women's Health Research Program at the University of Arizona College of Medicine in Phoenix. So two like really different kind of individuals. One that's very still clinical and also in an administrative role. One that's a lot more like very research based. So it gave me a variety of kind of inputs and viewpoints that helped me to determine, do I want to take on this project that I'm going to talk to you about? I come from a smaller department. GYN is fantastic, but our department had not participated in a clinical trial before. We don't have a designated research coordinator. And so when I was presented with an opportunity at a national conference about participating in a clinical trial, I was really excited, but also overwhelmed at the same time. Because when I talked to my division chief about it, or she's like, I haven't done this before. How do we get a research coordinator? Do you request this? It just seemed a little bit out of reach for us. So I had a lot of conversations throughout this mentorship program to see how can I facilitate this, and is this even possible? So it was possible. Spoiler alert. So the project that I'm participating in is called the LOTUS study. So quite the long title. So it's a multi-centered, open-label controlled study to investigate the effect of either LF111 or drospirenone chewable tablets on bone mineral density in adolescents and adult women in comparison to non-users of hormonal contraceptive methods. We can call it the LOTUS study. All right. So basically, it's a prospective, multi-centered, open-label, controlled, non-randomized trial. The subjects are those who want to take the trial medication. So LF111 is just drospirenone 4 milligram tablets, or the drospirenone 3.5 milligram chewable tablets. So the oral tablets have been available on the market for quite some time. The chewable is FDA approved, but has not been available on the market yet. And then this was compared to non-hormonal users in a 1-to-1 fashion. So I want to give a little background about what is drospirenone. I know all about it, but maybe not everybody else does. So this is a 4th generation progestin-only contraceptive pill. It's derived from spironolactone, but it has pharmacologic properties that are similar to natural progesterone. But because it's a derivative of spironolactone, it has anti-androgenic properties to it, which is one of the reasons why I use it quite frequently outside of this study. If you have somebody who, say, has PCOS, for example, but they have contraindications to using estrogen, great medication. It's progestin only, no venous thromboembolism risk, but it has that anti-androgenic property to it. So it can help with like acne, hirsutism, and also protect the uterus by, allowing for regular menses. So progestin-only birth control sometimes has a little bit of a bad rap in that it creates a hypoestrogenic state. Now, if you remember, estrogen is necessary to support bone mineral density. And so in previous contraceptive methods, so like Depo-Provera, for example, that medication in particular has been shown to have a negative impact on bone mineral density. And especially in the first 2 years, you'll see quite a drop in bone mineral density. Then things start to plateau after that, which is why it is okay for us to still use that medication even past 2 years. But this really kind of stimulated the question of, well, what about all of our progestin-only options? And so that's the point and the purpose of this FDA study, is to ensure, yes, we see that this medication is effective for birth control. We see that its general safety profile is reassuring, but what is its impact on bone mineral density? And that's the purpose of this study. At this point in time, the question is unknown, but they think that it doesn't have any clinically significant impact on bone mineral density, but that's again the point of the study. So the primary objective is specifically to look at the lumbar spine Z-score at baseline to 12 months as measured by DEXA scan. So our site is only looking at the adolescent arm. So the overall study looks at adults up to the age of 50, but we are only looking at 14 to 17-year-olds. This study has actually been going on for almost 4 years. They completely recruited the adult arm in the allotted 3 years. The adolescent arm, they've really struggled to recruit. And so they've extended out the study another 2 years to hopefully recruit the necessary participants in the adolescent arm. So they need to have had regular menses for at least 6 months. They need to be post-menarchal for at least 2 years, mainly because in that first 2 years after menarche, there's immaturity of the hypothalamic pituitary ovarian axis, you get irregular periods, and things aren't just quite as predictable as if somebody has been post-menarchal for 2 years. They need to have a normal blood pressure, of course, be willing to provide informed consent from the parent or guardian and assent from the participant. And then the study is going 13 28-day cycles, so a 1-year study. And they need to be willing to take that medication for during that time. And then the non-hormonal contraceptive arm, be willing to not desire pregnancy and stick to that non-hormonal option that they have suggested or selected. The exclusion criteria list is quite long, and that's some of the pitfalls that we've encountered so far in participating in this study. So any kind of contraindication to the medication, if there's like any kind of hypersensitivity to the active substance, if they have active current arterial venous thromboembolic disorders, they have benign or malignant liver tumors, there's significant hepatic or renal impairment, adrenal insufficiency, cervical cancer, any kind of hormone-sensitive cancers, undiagnosed abnormal uterine or vaginal bleeding, those would be, contraindications to taking this medicine. They need to have a normal baseline bone mineral density. So that would make sense. We're investigating if this medication negatively impacts your bone mineral density. If you are osteopenic to begin with, and there's a potential that we could make things worse, obviously you would be excluded from this participating. Any history of low trauma fractures. So that's like if you fractured something at like a standing height or lower, excludes fingers, skull, face, toes, like those kinds of things. But that may be an indication that there's some baseline low bone mineral density that hasn't been diagnosed or worked up. Conditions that are associated with low bone mass. So metabolic diseases like osteogenesis imperfecta, Paget's disease of the bone, osteomalacia, rickets, collagen vascular disease, so Marfan's, Ehlers-Danlos, which I have a lot of patients that see me, so it was a big exclusion criteria. Malabsorptive GI disorders, so like inflammatory bowel disease, they've had bypass, and then any kind of abnormal bone mineral density. So if they've got, hypo or hypercalcemia, hypo or hyperphosphatemia or hypomagnesemia, short stature, so defined as less than the 5th percentile. There's more. Any use of progestin-only contraceptive pills in the previous month, or the hormonal implants in the previous 6 months. So they do need to have kind of a washout period. That being said, if they're on a combined estrogen progesterone pill, okay, that they could participate, immediately stopping that estrogen progesterone medication and starting the progestin-only medication. Desire for pregnancy, eating disorders. With eating disorders in particular, so there's functional hypothalamic amenorrhea in an eating disorder, essentially kind of shutting down that HPO axis. So that's going to lead to a hypoestrogenic state. You remember, estrogen is needed for your bone mineral density, so that's why they're going to be excluded. Celiac disease, uncontrolled endocrine disorders. So if you've got a diabetic that's not really following their regimen, excluded. Same with our thyroid disorder kids, rheumatoid arthritis. And then there is a laundry list of medications. And that's also been something that's been a little bit of a struggle for us. In particular, I highlighted the ones that we kind of really have struggled with. SSRIs. So that was a learning point for me. It can impact your bone mineral density. So if they've been on that medication, chronic PPIs, certain anti-epileptic drugs, so phenytoin, phenobarbital, carbamazepine, all can impact bone mineral density. And then for Depo-Provera, if they have been on it for less than 2 years in the previous 24 months, they could participate, but they have to have a 2-year washout period. If they've been on Depo-Provera for more than 2 years, they can't be in the study at all. And then any contraindications to bone, like being able to actually perform a DEXA scan. So you've got hardware in the hip or in the femur and the lumbar spine, then they cannot participate. So this is a summary of the trial procedures. So we start with the screening visit, and all on the screening visit, we go over inclusion, exclusion criteria. We obtain our informed consent. We obtain labs. So we'll do urine analysis, urine pregnancy tests, CBC, CMP. Assuming everything there looks okay, we also get a DEXA scan. If their bone mineral density from a Z score is greater than -1.5, then they're eligible to participate. And then, so the screening visit, we do all of that in one day. It takes a couple of weeks for everything to come back. Once we say, yes, you're great, you can participate, then they come back for an allocation visit where we again confirm they're not pregnant, that they desire to participate, and then they get 6 months of medicine at no cost, which is great for them. And then we call at 1 month and at 3 months to check in to make sure that they're taking their medication, continue to not desire pregnancy, and that there's no, adverse effects that they are experiencing. At 6 months, the hormonal arm will come back in and do a midpoint DEXA scan to check in on bone mineral density. The non-hormonal arm does not need to do a midpoint DEXA scan. And then we check in again at 9 months. At the 1-year mark, hormonal, non-hormonal arms come back in. We do a DEXA scan, and then we look to see if there's any clinically significant or statistically significant impacts on bone mineral density with being on drospirenone for that year. So to date, we started around end of June, beginning of July. We've screened over 200 patients. We've had about 6 people who would want to participate and actually met the inclusion exclusion criteria. So one of the issues that we've had is a lot of people who are referred to us, it's for irregular periods, which immediately excludes them. We also have a lot of medically complex individuals who come to our department, and so immediately get excluded. But for the individuals who have been interested and have participated, so far we've received a lot of positive feedback and things have been going well so far. And we actually have a site visit tomorrow, just to kind of check in with the MedPace is our clinical research coordinator organization. And with that, I'll pause for any questions. Also, shameless plug, if you know anybody who would maybe want some contraception for free for a year, let me know. All right, Dr. Thornley.
Hello, everyone. Again, my name is Erin Thornley. I'm a pediatric intensivist here. And today we're going to be talking in a very general overview about host pathogen interactions in Staph aureus infections in children. I have no disclosures. The objective of this talk isn't to make you all experts in Staph aureus infection or the ways that Staph aureus interacts with our immune system when we do have an infection, but instead to, in general, recognize the burden of Staph aureus infection in our pediatric population, and to also explore some of the mechanisms by which Staph aureus can alter the human immune response, particularly to give some insight about things that are happening at the bench with investigators like myself or across the country to really try and understand some of these mechanisms behind Staph aureus infection and why some individuals are predisposed to recurrent Staph aureus infection, with the hopes that eventually this will serve as a foundation to create future preventative and treatment strategies. So bringing this back really to what matters is our patients, and that's why I research Staph aureus. One of the patients in fellowship for me that really triggered my interest in Staph aureus research is infant E. This was the first really sick patient I had in my fellowship and was a previously healthy baby girl with no known immunological impairment who had presented essentially with sepsis and was found to have a Staph aureus bacteremia that was the result of a spontaneous bacterial peritonitis. She initially had presented, like most of our infants do, into the ER with vague symptoms of fever, not really eating, lethargy, was initially admitted to the floor in stable condition and found to have Staph aureus bacteremia. Was started on all the appropriate antibiotics at the appropriate time, but still continued to quickly decompensate. And unfortunately, she developed multi-organ failure, septic shock, and unfortunately eventually passed away. And her story has really stuck with me. Staph aureus infection pre-COVID was the third leading cause of bacterial-related hospitalization in children in the United States. Depending on what study you read and what region of the country you were looking at, from 2000 up until the years right before COVID, Staph aureus infections in children increased anywhere from 100 to 300%. Largely, this is thought to be due to an increase in community-acquired MRSA infections. And up to 50% of children who develop a Staph aureus infection will go on to develop recurrent Staph aureus infections within a year. And we really don't know why. As I think many of you probably know and probably have seen, Staph aureus can present in a variety of ways in children. It can be a very simple colonizer that causes no disease process whatsoever. It can present as a very simple skin infection that gets treated with antibiotics outpatient, or it can develop with profound septic shock and disseminated infection. And the reason for this is Staph aureus is essentially fantastic and has developed multiple virulence factors to both evade and manipulate the immune system during both colonization and infection. And so just to take you back a little bit to microbiology and immunology, in order for some of this to make a lot more sense going forward, we're going to do just a quick refresher on the immune system. And so our immune system is made up of essentially two branches, our innate immunity and our adaptive immunity. The innate immune system is the one that we are born with, that is primed and ready to go. It doesn't need any previous exposure in order to recognize bacteria and viruses and to initiate an immune response. And then we have our adaptive branch of our immune response, which really depends on previous exposure in order to fight future infections and to identify future infections. And we have this kind of bridge here, which is the innate immune response that actually talks directly to the adaptive immune response. And our innate cells, such as our macrophages and our dendritic cells, we call them antigen-presenting cells. And those are our innate immune cells that are responsible for talking to our adaptive immune system and for educating our adaptive immune system on what pathogens to look out for in the future. And so for the remainder of this talk, we're primarily going to be focusing on T cells as one of our cell populations and how Staph aureus affects our T cell populations. And so the first question is really, how does Staph aureus affect T cell responses in infection? And this article, just in case anyone's interested in reading about this more, actually came out of my mentor's lab in fellowship, and really kind of discusses the impaired T cell function that we see in children and served as the foundation and the jumping off point for my research projects and my career going forward. And so we're going to talk a little bit about the background of this paper, just because it'll help you understand the projects that we talk about in the next few slides. And so what had happened in my mentor's lab during fellowship is we knew that about half of children will get a recurrent Staph aureus infection within a year of their first presenting one. And the thought process was that maybe that this was related to T cell dysfunction. And so what they did is they took children that were hospitalized with a known Staph aureus infection, and they took blood samples from these children during the acute infection process. They took these blood samples and they isolated white blood cells or leukocytes from the blood samples. And then they took those white blood cells and they cultured them with Staph aureus in a petri dish, and then assessed T cell responses in the presence of Staph aureus, so Staph aureus specific T cell responses. And what they found that overall is that when children are acutely infected with a Staph aureus infection, they have decreased T cell responses to Staph aureus. And the way they measured that was decreased amounts of cytokines that T cells secrete when they recognize a pathogen or an antigen. And so the question was, okay, so these responses are low during active infection, but do these responses recover after a period of convalescence? And so these same children were followed up about 8 weeks later, so enough time for the immune system to recover. And they followed up these patients 8 weeks after discharge. And they again took blood samples from these patients. They isolated their T cells from their white blood cells, and then they cultured them with Staph aureus again. And what they found is that in about 50% of these patients, they had recovery of their Staph aureus specific cell responses. And so when exposed to Staph aureus, their T cells did exactly what they were supposed to do, and they presented cytokines in the way that they were supposed to fight a Staph aureus infection. But interestingly, they also found that about 50% of patients did not recover T cell responses, and their T cells did not respond appropriately when exposed to Staph aureus. And my question going forward from that was really what causes these decreased T cell responses? And going back to our immunology circles, my thought or my hypothesis was that potentially our antigen presenting cells were being affected so that they couldn't appropriately activate our T cells and create that adaptive immune response. My cell of choice to look at was dendritic cells, and the reason that was because dendritic cells are the most important antigen presenting cell in a bacterial infection. And our immune systems really rely on dendritic cells to be able to recognize pathogens, uptake those pathogens through phagocytosis, present antigens, and communicate with our T cells to activate them and create both an effective response during acute infection and create that adaptive immunity for future infections. And so a little bit of background on dendritic cells. So dendritic cells, as you may remember from medical school, tend to live in our peripheral tissues. One that we think about a lot is our Langerhans cells that live in our skin. And these immature dendritic cells move throughout our tissues and look for infections such as Staph aureus. And when they recognize an invader or a pathogen, they will typically phagocytose that pathogen, digest it into antigens, and present those antigens on the cell surface. When dendritic cells find a pathogen in the periphery and they uptake that pathogen, as they process that pathogen in order to break it down into antigens for presentation, it'll move out of the periphery into the bloodstream or the lymphatic system. And it'll migrate to our lymph nodes, where it'll come into contact with T cells, present those antigens to T cells, and then activate those T cells both to fight the acute infection and to develop memory for any future infections. And in order for dendritic cells to effectively communicate with and activate T cells, it has to be able to do 4 things correctly. It has to be able to effectively phagocytose a pathogen. It has to be able to effectively process that pathogen and present antigens on the cell surface via MHC class II molecules. It has to appropriately express co-stimulatory molecules on the cell surface to communicate with T cells. And it has to secrete the right cocktail of cytokines in order to effectively tell the T cell what it needs to do. And any breakdown in any of these 4 mechanisms could potentially alter dendritic cell function and therefore T cell function. And so previous data had told us that Staph aureus has the ability to kill dendritic cells. This graph that you're looking at here is looking at the percentage of live cells in a blood sample, and then looking at the number of dendritic cells in healthy children and children infected with Staph aureus. And as you can see here, there's a decreased number of dendritic cells in children affected with Staph aureus. And this is largely thought to be due to a virulence factor of Staph aureus called leukotoxin. Leukotoxins are known to be lethal to a variety of white blood cells, but also to impair function in the cells that they don't kill. And based off previous data, I knew that leukotoxins, sorry, I'm just reorienting myself, that leukotoxins have the ability specifically to kill dendritic cells. And so this figure here demonstrates that. So on this y-axis here, you have, again, the percentage of live cells. And then on the x-axis here, you have your cells that were exposed to no Staph aureus, your cells that were exposed to a wild type Staph aureus that does secrete leukotoxin, and then cells that were exposed to a specific strain of Staph aureus in which leukotoxins are knocked out, so it cannot express leukotoxin. And as you can see here, dendritic cells that are exposed to leukotoxin have a lower level of survivability compared to ones that are not. And so my big question was, when dendritic cells are exposed to sublethal concentrations of leukotoxin, how does that affect their function? And so the way that I looked at this is I take blood samples from healthy adults, mainly because you need a large volume of blood in order to perform this assay, which is difficult to do in children. And I take the blood from these healthy adults and I spin it down and I isolate the white blood cells. I take immature dendritic cells and I expose them to Staph aureus either with or without leukotoxin and kind of incubate them for roughly 24 hours. This will give me mature dendritic cells, and I can then assess the function of those mature dendritic cells through a variety of ways. And so, kind of as a reminder of our picture previously, I can assess phagocytosis and the molecules that they're presenting on their cell surface through flow cytometry. And then I can measure the cytokines that they produce through an immunoassay. In the interest of saving time, so far preliminary data shows that leukotoxins don't affect the amount of MHC class 2 on the cell surface or co-stimulatory molecules on the cell surface of dendritic cells, but do have an impact on their ability to effectively phagocytose the pathogen. And so again, to orient you to this figure, on your y-axis here, you have the number of cells that were able to successfully phagocytose Staph aureus. And then on your x-axis here, you have our different groups. So this, again, is our control group where they weren't exposed to any Staph aureus. You have another control here where these cells were pre-treated with a chemical that inhibits phagocytosis. So that served as our second control. And then as you move across the x-axis, what you're seeing is dendritic cells that are exposed to either Staph aureus that does not produce leukotoxin or does produce leukotoxin at various concentrations, 1 to 60, 1 to 120, and 1 to 250. And what you can see is that leukotoxins impair the ability of dendritic cells to phagocytose in a dose-dependent manner. I apologize for this. And then I'm currently looking at how leukotoxins affect cytokines, but at this point, I don't have any preliminary data to share for that. And so future directions and where I'm taking this study currently at the bench is looking at how exactly leukotoxins disrupt the phagocytosis pathway. Do they actually inhibit the ability of the dendritic cell to engulf the pathogen, or do they affect phagocytosis by preventing the phagosome from maturing and acidifying, which you need in order to have effective antigen processing and presentation? And then the most important question is, does this exposure to leukotoxin impair dendritic cells to actively affect T cell responses? And then also at the bedside, my questions are, do dendritic cells function during acute, I apologize, does dendritic cell function during acute infection affect T cell responses both in the acute phase and after? Do dendritic cell T cell interactions, are they influenced by the severity of the disease? And does the severity of DC and T cell impairment predict patient outcomes and recurrence of infection? These are just some other areas of interest. I have a few projects going on right now and didn't have time to talk about all of them. But if anyone is interested in Staph aureus or has any interest in collaborating, either in a translational or clinical aspect, I'm happy to talk. And these are all the wonderful people that have previously or currently are helping me with my research. And then I'm happy to take any questions.
So thank you both. Really great job. And hopefully for those in the room, those of you online, I know we have a lot of general pediatricians in the community, and we have all of our general pediatric residents here. This was really to give everybody a glimpse into the type of work that is being done here and being done at sort of every level of research and education. And I think that was the value. Hopefully it wasn't lost on that. And hopefully the idea is that if there is interest in the room, that if you can hear about these projects, you can reach out to either one of these really great young physician scientists. Our inaugural class was 6 people, and we're just starting the process of recruiting our next class. And one of the things that we thought was really important when we picked this first 6 was that we asked them that to be part of this inaugural class, we really wanted them to have a role in shaping the future of this program, and to give feedback was really important, and figure out how we can really make this a beneficial experience for our own faculty. So are there any questions? Anything online, John? Oh, sure. You can both join me up here.
You want to turn on the overhead mics?
So we do okay, so now hopefully the overhead mics will be there, and then
Secret
okay,
sauce.
those are the secret.
Yeah.
Okay,
Slides.
okay, we want to take it back to this
Yeah,
one being request. Okay, okay, so that's our CME code. Okay, so my question is, for years they've always said for Staph aureus infections you can give, if it's MSSA you can give ANSEF, or if it's MRSA vancomycin to kill the organism, and then clindamycin to stop the toxins. So is anything in your research either support or refute that?
Not in my research specifically. Although honestly, a lot of that is just based on local sensitivity to specific antibiotics. And so, we can use Clinda here even for not just to stop the toxin, but actually treat the infection occurs in other parts of the country they can't due to high resistance. None of my research specifically has looked at that. I did a clinical study in fellowship as well, and found I had patients that were started on both clindamycin and vancomycin kind of prior to coming to our institution. What I did see is that initial antibiotic regimen, as long as it had some sort of staph coverage, didn't affect how persistent or invasive a Staph aureus bacteremia was. That's kind of the only research delved into.
Elimination for Staph aureus colonization, that affect any of the interplay, or how well they respond to infection?
No, that's a really good question. More research needs to be done in that area. And I actually have a huge interest in looking at nasal colonization of our patients and how it can potentially predict recurrence of infection or even antibiotic sensitivity. And so I already have the initial amount of patients that we have for that. So if anyone's interested in any sort of study looking at nasal colonization of Staph aureus, and if it's a predictor of patient outcomes or even treatment options, feel free to talk to me, because that's just sitting on the back burner waiting for somebody who's ready to do it with me.